Hello, everyone. Thank you so much to CurePSP for inviting me here. As Courtney mentioned, my name is Jocelyn, and I'm a palliative care specialist and movement disorders neurologist at Stanford University School of Medicine. That makes me especially glad and honored to be speaking with the CurePSP community. This is a group of people near and dear to my heart. I'm excited to talk with you all today about living your best life with PSP, CBS, and MSA. When we think about living our best life, I imagine that many of us think about scenes pictured here, being surrounded by friends and family, enjoying good food, enjoying pizza, being active, being outdoors, hiking. Some other things not pictured here might include participating in our church and our faith communities, caring for our loved ones, caring for pets, contributing in our jobs or work. These are all things that bring joy and meaning to our lives. As a doctor, I see that unfortunately for some people, illness can get in the way of us living our best lives. Illness can create challenges that make it difficult for us to access joy, meaning, or purpose. Those challenges can be physical, psychological, emotional. They can be practical and financial, even existential and spiritual. I'm here to talk more about how we can recapture some of that quality of life, that joy, connection, and meaning, even while living with a difficult illness. Over the course of the next 30 or so minutes, we will talk about an approach in medical specialty that focuses on making life as good as it can be. Along the way, I want to make sure to answer your questions, so please keep track of them, write them down, and we will have plenty of time for them at the end of this session. Today, we will cover the following topics. What is palliative care? How is palliative care different from other parts of medicine? When and how can someone benefit from palliative care? How does palliative care help people live their best life? And the difference between palliative care and hospice. To start, what is palliative care? I would like you all to think about what comes to mind for you when you hear that term, palliative care. As you gather those thoughts, I'd encourage you to jot them down, either with a pen on a piece of paper or on your notes application on your smartphone. I'd like you to keep those thoughts handy as we move through these talks, so that you can refer back to these initial impressions. I would like to start off by talking about what makes palliative care different from other medical teams. Firstly, in palliative care, we start with a perspective where we center our attention upon the person beyond the disease. We emphasize the individuality of every person we work with. This is our focus. How do we do that? Palliative care takes a holistic approach to someone's care. We think of the person and those close to them as the center of our care. That includes family, caregivers, and guardians, all the people part of that central unit. We also acknowledge that when someone is living with a serious illness or any illness that places significant burden on them, that there is more than just the physical symptoms. There's more than just the body that can suffer. We know that the body, mind, spirit, and practical aspects of life can all be affected by illness. Unlike a cardiologist who focuses on the heart or a nephrologist who focuses on the kidney, we don't just focus on a single organ or illness. We focus on the person and all the aspects of life that are affected. To make sure we address all the components of life that can be affected by a serious illness, we work as a team. In fact, often you may meet one or more of these team members during our visits. The doctors and nurses focus on managing bothersome symptoms and prescribing medications. We also help patients and families with medical decisions and advanced healthcare planning. We also help coordinate with the other doctors on your care team. Social workers can provide emotional support through regular phone calls, video visits, or check-ins. Palliative social workers can also provide caregiver support to your loved ones, help you access medical equipment, and talk through financial concerns and look for assistance if possible. Palliative chaplains provide spiritual support. They can offer prayers and blessings, yes, but what I really look for them for is helping people face their existential concerns, such as, why is this happening to me? Or how do I find meaning now that life looks so different? Chaplains hold space for those big existential questions, regardless of a person's spiritual or religious background. So far, we focused on how palliative care is different from other specialties, and I want to go ahead and provide a commonly accepted definition to dig in a little deeper. I'll start off by reading that definition, and then we can break down each component. Palliative care is specialized healthcare for people living with a serious illness. This type of care is focused on providing relief from the symptoms and the stress of the illness. The goal is to improve quality of life for both the patient and the family. Palliative care is provided by a specially trained team. Palliative care specialists work together with a patient's other doctors to provide an extra and essential layer of support. Palliative care is based on the needs of the patient, not on the prognosis. It is appropriate at any age and at any point in a serious illness and can be delivered alongside curative treatment. One of the first components of that definition that I just read is that palliative care is for people living with a serious illness. First off, I would say that any illness that has a reasonable possibility of being life-limiting over the course of years would be appropriate for palliative care. Some examples of illness conditions and diagnoses that we commonly see include cancer, heart failure, MSA, the other atypical Parkinsonian conditions, certainly PSP and cortical basal syndrome, Parkinson's disease, and ALS. In terms of the services we provide, one of the main ways we can help is to manage any symptoms that are keeping your life from being as good as it can be. Some of the most common symptoms we work on with patients include physical symptoms like pain, constipation, muscle spasms, increased saliva, as well as psychological symptoms such as irritability, impulsivity, anxiety, and depression, and hallucinations. And we can also be helpful with those larger, harder to define problems such as coping with illness, fatigue, and loss of appetite. How do we relieve symptoms in palliative care? As I mentioned before, we take a holistic or a whole person approach, and that applies to managing symptoms as well. Let's use insomnia or difficulty sleeping as an example. Let's say I'm seeing someone in my clinic who has progressive supranuclear palsy, and their care partner is telling me their sleep is just getting worse. Yes, they might be staying awake because their brain might be sending stay awake signals through their body, but it also might be related to that person's worry about their weight loss. It might be a side effect of an antidepressant. It might be related to not being able to find a comfortable position lying down due to their back pain. A patient might be so sleepy during the day that they grow more socially isolated from the people close to them. And when they're alone and staying up at night, they might begin to wonder if everything they're experiencing is a form of punishment from God. To address people's health as a totality, what we call total health, we consider what's happening in someone's body and also address how the symptom is affecting their life. So yes, our tools do include medicines. They also include psychological interventions, integrative techniques such as acupuncture and mindfulness, and addressing spiritual and existential concerns. In addition to helping manage symptoms, we help with making medical decisions. This can include things like advanced healthcare planning. We can help people complete documents like advance directives and post forms. And we also help with weighing treatment options. This could include things like helping a caregiver think through whether it's time to think about a feeding tube, whether it's time for someone to transition from home to a facility. We can help families prioritize what's most important in their loved one's care when time is looking short. As many of you likely know, making medical decisions is hard. making medical decisions in atypical Parkinsonian disorders, where there can be so much uncertainty about the future. When multiple specialists or family members can have different opinions on what's the next best step, decision-making can be even more challenging. This is honestly my favorite part of the job, helping people weigh the benefits and burdens of treatment options within the context of what's important to them. Palliative care is here when you and your healthcare team need it, and that means at any age and at any stage. There's no particular age, diagnosis, prognosis, or treatment plan that makes you eligible or ineligible for palliative care. And it is extremely important to know that we can be helpful anywhere along your journey with an atypical Parkinsonian disorder. In a typical clinic day, I see people who have been newly diagnosed, patients who are pursuing treatment, patients who are engaged in clinical trials, and of course, patients who are working to live, to thrive with their illness and not receiving treatment targeting their underlying illness, all of the above. Among palliative care circles, a joke that we have is that if our services were a pill, we would be the next big blockbuster drug. Part of this comes from the results of a landmark study published in the New England Journal of Medicine. This study showed that people living with newly diagnosed advanced lung cancer actually had a survival benefit when they received consistent monthly outpatient palliative care visits. Patients who got palliative care lived an average of 3 months longer than those who did not receive palliative care. Across many studies of people living with many different diagnoses, palliative care has demonstrated consistent benefits for patients and families. These include improved quality of life, lower symptom burden, improved spiritual well-being, improved psychological symptoms, and greater satisfaction with care. Many of these studies have also shown that people engaging with palliative care have fewer hospitalizations, spend fewer days in the hospital, and that caregivers have their burdens lessened. Many people wonder, when should I ask for a referral to see a palliative care team? I would say that if you are living with a serious illness such as PSP, CDS, or MSA, palliative care could be right for you. We can be especially helpful if you're having difficulty with symptoms, difficulty with decisions, or difficulty coping. Our team is also particularly helpful if you feel that multiple aspects of life are becoming difficult and that your illness is affecting your mind, your body, or your spirit. How do you access palliative care? A lot of people wonder if palliative care is expensive. Many people wonder who pays for it. Palliative care would be covered by insurance like any other medical specialty that someone might be seeing. For example, it would be covered just as you see your neurologist or perhaps as you see your heart doctor. The first step is to ask for a referral from another provider, and that can come from a primary care provider, a specialist like your neurologist, or doctors in the inpatient medical team or the emergency room. They might be able to make a referral depending on someone's insurance plan. I want to address a very common question that people ask me when they first meet me in clinic. First and foremost, palliative care and hospice are not synonymous, although I will advise you that many people, including many well-meaning and well-educated healthcare professionals, will conflate and confuse these terms. So I'm glad you are all here to help me get this correct. As we have described, palliative care is a large and broad field focused on symptom management and helping make sure the care plans focus on what matters most to patients. Again, we are here for patients of any age, at any stage, and can be involved in addition to even curative treatment. Hospice is a part of the type of care that palliative care providers are trained in, but it is only a part of what we provide as a field. Hospice care can be a little confusing because the term really refers to several things. Hospice is often used to describe a philosophy of care. Hospice is also a health insurance benefit that is included in all insurances. Hospice is a set of services that can be provided in any setting, a home, a facility, or a hospital. As a philosophy of care, hospice focuses on supporting patients for whom comfort and quality of life is the highest priority. In providing this type of care, hospice typically thinks about every intervention, lab test, medicine, and asks the question, does this help the person feel more comfortable? If it does, hospice will try to do that thing and make it happen. If it does not, hospice will recommend stopping that test, medicine, or intervention. Again, the philosophy of care for hospice is a really good fit for people who want quality of life and comfort to be their number one priority, which often includes that patients are less focused on pursuing interventions that might prolong life and might prolong the dying process. As a philosophy, hospice also aims to support people being in the place that is most comfortable to them. For many people, that happens to be the home. Hospice does everything they can to make people as comfortable as possible while keeping them in the home, and typically they work to avoid going to the hospital. For some people, being in the home is not what is desired, and so hospice services can be provided in nursing homes and even in specialized hospice facilities or hospice houses. As an insurance benefit, hospice services are covered under every insurance plan. There are regulations and guidelines that hospices must follow. Medicare provides the guideline that patients should have a 6-month or less estimated prognosis to be eligible to receive hospice benefits. The philosophy of hospice, again, is to provide comfort-focused care. Therefore, hospice may or may not pay for certain treatments that do not provide more comfort. Although there is more and more variability in what certain hospice agencies will cover and allow under their care. Talking with specific hospice agencies about individual cases is always helpful, as unique situations happen frequently and everyone's circumstances are different. Hospice as a set of services is very comprehensive. This is going to be a busy slide, so I won't cover everything in detail. Of course, I'm happy to answer more specific questions about hospice services in the Q&A. Hospice agencies are composed of an interdisciplinary team, similar to a palliative care team. Those people include the doctor, the nurse case manager, social worker, chaplain, volunteer, and home health aide. Hospice can be delivered and received in the home, in nursing homes, and in specialized facilities in some cases. Hospice provides you access to a 24-hour nurse phone line that is staffed every weekend, every holiday, every night. Hospices have the ability to send a nurse out to see people when needed, often that very same day. When people enroll in hospice, hospice also takes over responsibility for prescribing all medications needed for symptom relief, as well as providing medical equipment, including things like a hospital bed, bedside commode, and/or wheelchair. It's important to know that hospice has the ability to move people if it turns out their care needs are not being met in the home. Hospice does not provide 24-hour care nor pay for room and board, but they can facilitate a transfer to a facility and add on to the care that people are receiving in the facility already. As we wrap up, I wanted to share some resources in case you're curious about learning more about palliative care and hospice. Here are some resources about palliative care. Our Stanford Palliative Care website takes you through much of the information that I've shared with you today. And I wanted especially to highlight the link at the bottom. I know there are many people potentially across the country that are watching this program right now. And the bottom link, getpalliativecare.org, allows you to put in your own zip code to determine a palliative care program near you. As a take-home message from today, I hope that you will remember that if you are facing a difficult road, palliative care is here to partner with you, your family, and your neurologist, and they're here to help you carry that load. To finish off, I wanted to include a single slide about the emerging field of neuropalliative care, because a lot of people ask me, as a neuropalliative care specialist, what is the difference between palliative care and neuropalliative care? I defined neuropalliative care as an interdisciplinary, specialist palliative care for people living with serious neurological disease. So everything we just talked about in regards to palliative care applies to neuropalliative care. However, I do think there are several things that make neuropalliative care even more specialized. The neuropalliative care field, all the doctors, all the social workers, all the nurses, all the advanced practitioners, all the chaplains hope to be part of the forefront of meeting the massive public health challenge in our country as the population ages and the prevalence of these neurodegenerative diseases like PSP, CVS, and MSA increases. The biggest priorities of the field include providing more support to people like you, to patients and families as they plan for the future. We also hope to ensure that care partners and families are supported through often a long and sometimes uncertain journey. And one pet project that is very important to me in my own work is to really work on ways of encouraging earlier conversations surrounding values, hopes, worries, and goals when patients are able to participate fully and as independently as they want to. If you or your family have any interest in contributing your invaluable experience to this field, I highly encourage you to look up the International Neuropalliative Care Society, or INPCS. Your experiences with atypical Parkinsonian disorders should be at the center of all of our efforts, and lending your voice to our professional societies is one important way of getting involved. Thank you for all of your kind attention, and I'm happy to take questions for the remaining minutes of this talk.
Great. Huge thanks, Jocelyn. That was really so informative and helpful and dispelling myths between palliative care and hospice. And I know that's a passion of yours. So awesome. I'm going to ask you a few questions that we got both in the chat and also from questions on people's registration. The first one is, can you please just elaborate briefly on what advanced directives are and specifically what something like a pulsed form is, or a MOLS form?
I'd love to talk about that more. So thank you to whomever put that question in. Advanced directives are legal documents that a lot of people tend to fill out when they might be estate planning with a lawyer, but don't have to be. They are documents in which you as a patient can designate if you were ever to become so sick so that you could not speak for yourself, you could designate a surrogate decision maker, essentially someone who can speak on your behalf, someone who's familiar with your medical conditions and familiar with you as a person, knowing what's important to you, so that that person can help doctors make decisions that would really support who you are and to customize the care plan to uphold your own values. So that's, I think, the most important piece of an advanced directive. Often, advanced directives can also include other kinds of discussions surrounding what kinds of care you would be open to receiving in the future if you were ever to get sick. So a lot of them, ask about your preferences for really advanced therapeutics or life support interventions like resuscitation and intubation. I often encourage people to really think of advanced directives as an impetus to have conversations with the people important to you. Our data looking at advanced directives really shows that the most important product of these documents is actually the fact that they spur important conversations that might be difficult otherwise to have with those people who might be making decisions on your behalf. In contrast, a POLST or a MOLST form are a physician's or provider's orders for life-sustaining treatment. And they actually are a one-page form, and they can vary from state to state. They will ask a series of questions of different kinds of interventions that you may or may not be open to. They almost always include a preference surrounding resuscitation, which is what would you want, any kind of EMS or paramedic to do if you were to be found without a pulse and having died. After that, the pulse or the MOLS have some other more fine-tuned questions about what kinds of care align with your goals. Typically, when I work with families to think about advanced care planning, I like to take everything from the broad perspective of what's most important to you, knowing your diagnosis, knowing what we expect in the future, and knowing what the potential outcomes of these different interventions might be specifically for you. I really like to discourage actually the use of them as a menu to just kind of check on and off about, because they really should be rooted within your medical context and your diagnosis. But I won't go much further into that because I'm sure there are other questions, but thank you again for the great question.
That was great context. Thank you. My next question is, let's see, I'm trying to decide between so many lovely questions. What would you recommend to someone who doesn't have a designated palliative care clinic accessible to them, whether geographically or otherwise?
Yeah, I think, that's such a great question. The palliative care field, and especially the neuropalliative care field, which is even smaller than the big palliative care field, is really cognizant about the barriers to access that a lot of people experience. My general advice would be there are a lot of online resources for patients and families about kind of this palliative care approach and mindset. And I really would encourage you to really, advocate for yourself and to share these resources with whomever, whatever provider you might have on your care team. That could be your primary care doctor, that could be your neurologist, that could be a social worker that you might be connected to, that could be your faith community leader, just to share with them that there are so many things that you recognize are being affected by your illness, and that you could build together the team of people that can provide you this kind of approach to palliative care. Often in palliative care, we distinguish between what's specialist palliative care, so that's provided by a palliative care team, versus what is primary palliative care, meaning the kind of natural palliative care that so many people are providing in their day-to-day work, and they just don't name it that way. So there's so many amazing primary care doctors and neurologists who are talking with people about what's important to them, helping them plan for the future, supporting caregivers, addressing the spiritual and existential concerns of patients and families. So they are really already doing that. So finding who those people might be in your community is what I would recommend.
Awesome. That makes a lot of sense. The next question is one from the chat, and it is, if the person with a diagnosis isn't interested in palliative care, could the care partner, however, reach out to the palliative care team for just general advice?
My advice regarding that, so in order for a palliative care team to have an initial visit with you, the person with the diagnosis usually has to be, at least present for the initial kind of meeting. I will say it from a practical perspective in my clinic. Often there might be more or less interest on the person with the diagnosis in participating in the conversation with me, or they may or may not be able to have the conversation with me. So I might spend the bulk of my time, the vast majority of my time, working with the care partner, working with the family member. In order for any specialty medical clinic to technically see a person, there needs to be a referral for the person with the diagnosis. But I think if you can communicate with your loved one, with the patient, that this is actually a service that I'm looking for me, just so I can garner more support. I wonder if that's a way for them to join for a little bit at the beginning of the visit, and then potentially go to leave for the rest of the visit, so that you as a care partner and the person writing that question can still access the services. Otherwise, I will say there are a lot of wonderful caregiver resources. I'm sure many of which the CurePSP organization has highlighted in multiple ways through this virtual care conference and also on their website. The Family Caregiver Alliance is an amazing nonprofit organization that really focuses on caregivers, on care partners, and many of the resources that I've kind of discussed, ways of accessing more support can be found through kind of more specific caregiver resources as well.
Great. We had another question in the chat about someone who kind of received some pushback from their care team about receiving palliative care. Do you have some advice that you would give them when it doesn't seem to have been their neurologist. They were told that palliative care is typically for people with cancer. And so do you have any advice or verbiage that people can use kind of in those scenarios?
Yeah, I've definitely sympathized with that, feedback. I've definitely heard similar things from the patients that I've worked with. Just to provide some context, the palliative care world grew out of oncology, out of the kind of comprehensive and multidisciplinary care that now exists for people living with cancer. So necessarily, with the growing pains of the field, there are practitioners or providers who might still envision palliative care as primarily being rooted in oncology or the care of people living with cancer. So I would, advocate to whomever is wondering this when they're in that conversation with their provider, to be able to help educate them a little bit and say, actually, I heard that palliative care is available for anyone with a serious illness. And a serious illness is pretty much any illness that might be reasonably life-limiting over a number of years. And if it's the education gap for that care team, that maybe that, kind of reframing and that education will be helpful enough to kind of help them understand why you're asking for palliative care and how it can be helpful for you. I will also normalize the fact that there are some palliative care teams that just based on their size and based on their funding have primarily directed their services to be limited to only people with certain diagnoses. So it would be helpful to understand from your care team that you're receiving this feedback from, is that feedback coming from the palliative care team, or is it coming from kind of that educational gap, like we said? The educational gap is something that you can, kind of provide some feedback for and help educate and to kind of address and target. If it's coming from the palliative care team itself, saying that, because of our clinic model, we're only able to see people living with certain diagnoses at this time, then that helps you understand that maybe asking for referral to a different palliative care team might open up other options for you.
That makes a lot of sense. Great, thanks. And then I have a few questions about hospice. Of course, anyone feel free to keep asking questions in the chat. The first one is, do you have any advice on signs that may indicate it's time to transition to hospice or inquire about hospice?
Yeah, I think that is a really important question, and one that does actually require a fair bit of specialist expertise to answer. So I will say that is something that I could talk about for probably an entire hour, because there's this is a really new field and a really different and innovative way of thinking about care, neuropalliative care. So there are a lot of questions that are yet to be answered by the research to really answer this. I will say generally, for people living with a neurodegenerative condition, so anyone living with PSP, CBS, or MSA, there are a few general markers that I'm looking for that are indicating to me that time might be growing shorter for them and that they might become eligible for hospice. And I will just say out loud, not everyone wants to know this kind of information. So if you feel like this kind of information is helpful for you, please feel free to keep tuning in. And if not, then you can pause for the next 2 minutes while I speak about it. So the general markers in people that I'm looking for that tell me that their prognosis might be shorter, or that might be time to think about transitioning to hospice, or at least offering hospice, include more difficulty with swallowing. That can be a really powerful marker for many people. anything involving swallowing, anything involving appetite loss and weight loss, and generally, decreasing nutritional status, so becoming more frail, being less active, spending more time in bed. And then I'm kind of looking at these big markers, like how engaged are they? Are they spending most of their days sleeping and not really speaking anymore? How much are they able to attend, even by opening their eyes or track things? And certainly, a pattern of illnesses like recurrent infections or recurrent falls might indicate to me that that time is growing shorter and that they and their family could use the kind of support that hospice might bring. So this is all, that might all sound a little bit on the vague side, and I will say that um, in general, prognosis is a difficult art in neurology. So often when I'm speaking to an individual family, I might give them these general markers to look for that help me guide people when I'm thinking about when to introduce hospice or not. But it really does tend to vary from person to person. And so the advice often should be customized to the individual and the family.
Great. The last question I have, unless folks want to keep typing them to the chat, is just maybe some clarification of hospice myths. I know that people probably have heard all sorts of stories about people being on hospice for years, and okay, that's not a myth, but just an explanation of how that happens and why.
So if I can call your attention back to the hospice slide where we kind of talked about that Medicare guideline requiring that people have more likely than not 6 months or less left in their lifespan in order to qualify for hospice. You can hear just in the way I'm talking about it, there are a lot of words there that indicate, more likely than not, estimated, that indicate that the art of prognostication, like I was saying, is pretty difficult. We're pretty bad at it. So that means that often hospice, when they're checking in on a patient and they're meeting them every week, they are also trying to figure out for themselves, is this person declining still? Am I agreeing and seeing that there are signs that this person is reaching the end of life? Some people, after 6 months on hospice, they actually can plateau and seemingly stabilize. Some people even get a little better, and that might be because their symptoms are better controlled. They're more comfortable. Their families are better supported. All sorts of things might be addressed by the hospice services themselves. And so there's a minority of people who actually kind of do well on hospice, and they might stabilize to the point that hospice at the end of 6 months says, well, that's interesting. It does seem like things have kind of shifted compared to where you were 6 months ago. And so then hospice will then recommend that you graduate from hospice potentially and unenroll with the understanding that you can always access hospice again if and when it seems to be a good fit. At the end of 6 months, if hospice comes back to that patient and family and say, well, actually, things, certainly someone's outlived our expectations and our prognosis, but we are still seeing signs of decline. We are still confident, more likely than not, that they have less than a 6-month prognosis. In that situation, hospice can recertify someone. So decide to continue services if they feel like the services can be justified by Medicare criteria. And that's usually the case when people do end up living longer than those 6 months and hospice stays on board.
That makes a lot of sense. Great. Well, Dr. Jiao, thank you so much for joining us. This was beyond informative, and I'm grateful for all the time that you spent. Yes, of course. And everyone, I do encourage you to check out CurePSP's resource on palliative care and hospice. It's on our educational resource webpage.